T-cell immune effector cell therapy is something that I spend a lot of time thinking about. And in my role as a phase 1 investigator, we have partnered very closely with our hematologic colleagues. So the doctors taking care of patients being treated with CAR T-cell therapy approved for lymphoma, leukemia, and increasingly, we think perhaps for myeloma as well. I've learned a lot from the heme guys that run the immune effector cell program at Sarah Cannon. They love to tell me how poor my car is compared to their car. Picture a Porsche versus a Chevy. But because I think solid tumor immune effector cell therapies have a long way to go. And part of the reason for that is because we don't have a CD19 target, which of course is the relevant target for all 3 CAR T cells that have been approved in the treatment of hematologic malignancies. However, the idea behind immune effector cell therapy that you could take the T cells from a patient, remove them, educate them, and then with some lymphodepletive chemotherapy, put them back into the patient and have them hone to the tumor and stimulate other immune effector cells to do the same. Makes a lot of sense. It is going to perhaps be an effective therapy where T-cell checkpoint inhibitors are not. We are evaluating solid tumor patients with a number of targets with both CAR and TCR trials. In addition, we even have a CAR T cell or an immune effector cell therapy using red blood cells from Rubius that is exciting as well. One of the challenges of immune effector cell therapy right now in the solid tumor arena is that it feels as though all of the trials are competing for the same patients, because for most of the time, clinical trials require that we find a target or a tumor antigen of interest. We have to do a lot of screening in advance of tumor tissue to find the right target. The TCR trials require an HLA, for the most part, HLA-A2. And so we're doing a lot of HLA testing to try to find those patients that would be eligible. My Christmas list for 2021, I guess, or my wish list would be that there would be a more universal way we could screen and identify appropriate patients across trials so that we wouldn't have to, it feels right now like we're competing to figure out which tumor type or tumor tissue to send to which trial, and that shouldn't be the case. So there's a lot we need to understand further. Yet it's a very exciting area and something I'm grateful that Sarah Cannon has decided to invest the resources to develop for both solid tumor as well as hematologic malignancies.